Good morning. It's Tuesday, October 11th. I'm Jessica Lovell. Coming up on the Morning Medical Update, a cancer diagnosis is devastating, but the promise of clinical trials and research on the horizon gives hope to many facing the unknown. Health experts expect a winter surge for the third year, but it's not just the COVID factor. Why hospitals are bracing themselves. Thank you so much for joining us here on Facebook, YouTube, and on Twitter. We are live here inside the Dolph C. Simons Jr. Family Broadcast Studio. Please get your questions sent in to us via the links there on your screen, or as always, you can post them in the chat below. We'll get to those here in just a bit. Today, people are living longer lives from successful cancer treatments that often begin as a clinical trial. Through clinical trials, doctors determine whether new treatments are safe and effective and work better than current treatments. Joining us today is breast cancer patient Tracy Mason Solis, along with two breast cancer researchers, radiation oncologists, Dr. Julia White and Dr. Shane Steckline. So good morning to all three of you. Welcome.
Thank you.
Thanks for being here, Tracy. Good morning to you. Always good to see you. Tracy, tell us a little bit about your initial diagnosis.
I was diagnosed with invasive lobular pleomorphic carcinoma. And I'm only HER2 positive, ER/PR negative. So it made it rare because the type of cancer I got doesn't usually happen to women under the age of 65.
And you were how old when you were diagnosed?
41.
So this made this a very unusual case from the get-go.
Yeah.
Tell us about your cancer treatment.
My surgeon I had was Dr. Jamie Wagner, and I had Dr. Day as my oncologist, and they did such a good job in keeping me alive. On the days that I didn't want to be here, they made me be there, and they're the only reason I survived so far.
Well, and we've kind of been along with you for this journey, and we are so glad that you are here too. I want to talk about the breast cancer trial that you were on. It didn't have anything to do with the treatment that you took, but this was actually post-treatment. You took part in a chemo brain trial. Tell us about that.
After chemo, I started to realize that I had to start putting my GPS on when I left the house. Things like this, in the middle of sentences, I would forget what we're talking about. I'm also part of Pivot. I don't know if you've heard of it, but we're patient advocates. And I was lucky enough to be on a clinical trial from that. And it was for chemo brain, and it really, really helped on repetitiveness. Writing things down. I started keeping a journal of every day of what I ate, what I drank, who I saw, what doctor's appointments, everything like that, so I could go back and remember. Because you could tell me something and I could forget in 5 minutes.
Did you see a result from that trial? And how are you doing today?
I saw some. A lot of them are good results. A lot of them are, I still have it. But it's gotten better. It's gotten better.
Better?
Yes, it's gotten a lot better.
Dr. White, I want to bring you in here. First of all, I want to introduce you and welcome you to the health system and welcome you to our program as well. Dr. Steckline, one of our great experts as well. But Dr. White, you're a national breast cancer trial expert. You have served as the principal investigator on a number of important clinical studies that have helped establish the current standard of care in the treatment of breast cancer patients. And I want to talk to you about trials that you're currently involved with. But is better good? When Tracy says, I'm doing better, is that good? What is the result after a trial or somebody goes on one that you're looking for?
So I think it depends on what the question is, right? Mm-hmm. So a clinical trial poses a question that's going to solve a clinical problem, right? Mm-hmm. In Tracy's case, she was having this problem, chemo brain, which is like a big deal. It sounds like it was interrupting your life. Getting from point A to B was a difficult. So that it really brings in the importance of trials aimed at improving survivorship. We want to cure people with our trials, right? But we also want to make your life be as it was, as close to possible prior to diagnosis. And so this is the survivorship type trial. Survivorship begins with your diagnosis. So the fact that the trial just basically taught you a skill set, it sounds like, gave you some cues and some pathways to help you get back to doing the things you want to do. I think that to me would be a successful outcome of the trial. Now, I'm guessing that. What's important in a trial is that you pose the question to solve the clinical problem, but make sure the trial is organized as such that we get a clear answer. So the people who ran this trial for you, Tracy, I bet you they were so excited with your participation because you'll contribute to that body of knowledge that will help women behind you. You're getting some benefit, but the next generation of breast cancer patients will get a ton of benefit. So thank you.
Dr. White, you're nationally renowned in breast cancer research. Tell us what you're involved in currently. What's on the horizon with you?
So I am most of my focus is on the local regional management of breast cancer, which means how do you manage the breast after diagnosis, and in particularly what is the extent of surgery and the extent of radiation necessarily to get women to the point where they don't need to worry about cancer returning here. As we know, there's always two paths for cancer recurrence. One is the risk it'll come back where it arose, in the breast or in the surrounding lymph node area, or will it travel to a distant site? And I think I don't want to minimize the traveling to the distant site. I think that is our number one battlefield in breast cancer, and there's a lot of really great clinical trials going on to answer that question. But in how we manage the breast, my interests and my trials have been focused on making sure we choose the right local regional treatment for the right disease for the right patient, and making sure the patient has a voice in that decision, so that she can, if she can, elect to keep her breast, elect to not keep her breast, and that she feels happy about how she looks afterwards. So right now the trials I'm looking at is, do we need to radiate every patient? So one trial is, we call it the DEBRA trial. It's taken us a long time to get up and running, and I'm PI on it, is finding, and this is where we're using the intersection of technology and biology in radiation treatment for breast cancer, and say, we have figured out the best technical way to deliver the breast, but can we use biology to say whether we need to do it at all? And so we're using this in a very specific subset of breast cancer patients who went and got a mammogram and got diagnosed early. They have stage 1 disease, and it's responsive to endocrine therapy. So that's one trial. Similarly, we have another trial, BR008, which is Energy BR008, is going to ask that same question in early patients who have an early diagnosis of a HER2-positive breast cancer. So all you might need is the HER2 medicine and chemo, and you wouldn't need to take the radiation if you want to preserve your breast and just get a lumpectomy. That's an exciting trial. I'm also involved as a co-investigator on a Canadian trial asking the same question for women who have more advanced disease, node-positive disease. Do we need to irradiate all of those? Can we elect to omit it? So it's really about taking that intersection of biology, what we understand about breast cancer biology, and understanding what we technically can do to give radiation, if we need to give radiation to minimize long-term toxicity, to maximize cures, but also try not to give it to everybody.
Dr. Seckling, you're a translational physician scientist. First of all, what does that mean?
So it basically means I wear two hats, and so in many cases, we need two different types of research to bring new cancer discoveries forward in advanced cancer medicine. One of those is basic research that's focused on mechanisms of disease and identifying new therapies. The other is clinical research, where we bring those discoveries into patients to improve patient outcomes and survivorship. And in many cases, those two different research realms, they're kind of siloed and they exist in isolation. And the goal of a physician scientist is to really bridge that gap. And so in addition to being a practicing physician, I also have a PhD in cancer biology, and I lead a breast cancer research lab that's aimed at identifying new strategies that are better than what we have today.
So I understand that you're leading a new investigator-initiated trial in triple-negative breast cancer. Tell us about the trial, what it's testing, and what you hope to learn from this.
Sure. So my primary interest is in triple-negative breast cancer, which accounts for about 15% of breast cancers in the U.S. We know it's a disease that disproportionately affects young women, it affects black women, it affects women who carry germline mutations in a tumor suppressor gene called BRCA1, or what some people refer to as BRCA. And compared to the other subtypes of breast cancer, triple-negative breast cancer has worse outcomes. It has higher risks of the cancer coming back both in the breast and the lymph nodes, as Dr. White discussed. It's also much more likely to spread elsewhere in the body. And those patients have poorer outcomes compared to patients with non-triple-negative breast cancer. Right now, the standard of care systemic treatment, meaning that the treatment that we give through an IV that treats the whole body, is a combination of 2 chemotherapy drugs plus immunotherapy, and then 2 additional chemotherapy drugs and immunotherapy. And that may be overkill for a significant proportion of patients, because triple-negative breast cancer is really a disease that's defined by what it's not. And because of that, it's a disease that is really heterogeneous. And we see that some patients do very, very well and some patients do very poorly. And even though we call them the same thing, these are biologically different diseases. The trial that we're starting is called Neotract, and it's testing the idea that we can use 2 previous observations, one being that breast cancers, or triple-negative breast cancers in particular, that have a lot of immune cells in the tumor, respond really well to anything you throw at them, chemotherapy, immunotherapy, any sort of systemic treatment. And the other is that doing an MRI halfway through treatment is a reasonably reliable predictor of what the pathologist will see under the microscope at the time of surgery. And so we're taking women who have these immune-enriched triple-negative breast cancers, testing and quantifying the number of those immune cells that are present, and using that as a guide to help optimize therapy for those patients on an individual basis. We start with the same chemotherapy in everyone, and if they have a really good response on that MRI, they go straight to surgery. And if there's no residual cancer, then those patients don't need any additional treatment in the adjuvant setting. And so it has the potential to dramatically reduce the intensity of treatment for those patients while still preserving a really good outcome.
So for you two to do your work, you have to have trial participants. So that's why people like Tracy and others who participate in those trials, they matter. Tracy, what questions did you have, or what advice do you have for somebody maybe who's been presented with the opportunity to be a part of a trial as a patient, breast cancer or in any other health area? What would you say to them, and what questions might they ask their physicians?
I would definitely ask at what stage is the trial under, what kind of results has it shown, I think those are really big, important questions, because if they're like in stage 1, I would probably not do it. Now, if it's been tried and it's gonna get FDA approval, then likely I would try it. I know that some clinical trials, I know people who have good results out of clinical trials, and I know some that have bad results. But everybody's different, and without clinical trials, how are we supposed to move forward to help somebody else in the future?
Right. That's such a good point. Dr. White, what are those conversations like? I know you're on the research, but between you and the physicians that are then treating the patients, how are we making these patients who are willing to be a part of the trial feel good about where we're at in the trial?
I think that's a great question. And again, I think Tracy really touched on some really important points. Mm-hmm. And we really try our best to match the potential risks of the trial to the seriousness of the diagnosis. Mm-hmm, mm-hmm. So for Tracy, who sounded like she had a curable breast cancer, and again, we're trying to solve a clinical problem here. She had this memory issue. Mm-hmm. A trial that was about learning new skills, learning an intervention that doesn't really have significant harms other than using your time. I think it has pretty low risk. And that sounds like it was not a comparative trial, meaning a randomized trial. Mm-hmm. So the trials encompass a large different types of intention. I think we have patients who are very, very sick with advanced disease who are at the end of their available therapies for them, and we want to try to give them and the next patient after them an opportunity. And this is where we do phase 1 trials, where we have a new medication that we need to understand how it interacts with the patient, how it absorbs into the body, how it affects things. And the phase 1 trial for those patients, and my experience with those patients is they're very happy to have a trial. They know the seriousness of their situation, and they may be willing to take some more risks than, say, Tracy would with a curable, very curable cancer.
And a lot of your research involves trying to minimize those side effects, but also balancing the most effective treatment.
Absolutely, that's what phase 1 is about. What is our safety here? Can we give this drug and can we give this drug or this intervention and make it safe? So that is like the key thing about phase 1, something new, but something safe. And then we have the kind of the intermediate group that's helping us make sure we have the right dosing and then we see an effectiveness. And then by the time we get to our largest trials, like the ones that I do, large phase 3, both treatment options are good. Yeah. They're both really good. We just want to know what's the standard of care. What should we be doing? And so essentially low risk because either one has known risks.
So Dr. Secklein, there's been a lot of excitement about proton therapy available here in our area. What's the application possibilities for breast cancer? This is something we're moving toward. I want to hear from both of you on this.
So, as you all know, we started treating our first patients in May of this year, and we're all very excited. There's been a tremendous amount of interest from the community. There are certain patients and certain patient populations, most notably our pediatric patients, where the benefits of proton therapy are very clear. I think it's a more complex answer for breast cancer. Now, we can use proton therapy to treat any subtype or any stage of breast cancer. We just at this point don't necessarily understand the clinical benefits and whether they exist sort of in a broad sense over conventional radiation therapy. As an aside, there's an ongoing randomized trial that's asking that question, photon versus proton radiation therapy, and that will really be the first high quality evidence we have to try and give us some insight into what the actual benefits are. As best we understand now, there are some patient populations who may benefit more from proton therapy. I won't go into all of the details, but those are, we have this as an available tool, and if we see those patients in clinic, it's something that we can consider offering if we think that it will give that patient a substantial benefit.
So, Dr. White, that was my next question, is what type of patient might this work for?
So a lot of what I have done in radiation is try to really make the technical delivery more precise. And then along with technical delivery to target the breast is this ability to avoid organs at risk that you need. We don't want to over-irradiate. And I think that ratio of benefit from radiation versus harm is where I personally see a lot of optimism for protons to back us up with what we have right now. We have a lot of technology that allows us to deliver radiation so much more safe than when I came out of training 1,000 years ago. And so I think what protons does is give us another opportunity to help those women for whom we were really worried that maybe the heart dose was higher. We really want to do this radiation to help control her cancer, but we're really worried about harms. So, I'm excited to have this ability to explore this. And this is what the clinical trial, the RADCOMP clinical trial is going to do. But within our group here, we also will continue to push forward to understand what's the best patient for protons in breast cancer.
Let's check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, joining us with our COVID count and some COVID headlines. Good morning.
Yeah, hi. Yeah, we thought the numbers were going to trend down. They're just kind of really bouncing around right now. As far as active infections, we have 28 active infections in the hospital, with 3 in the ICU and 0 on the ventilator. Still 20 in that recovery period as well. Total number of reported cases is continuing to go down, as well as hospitalizations nationally. But certainly we know in UK and Europe, there is an increase in the rate of cases at this point in time as well.
All right, so hospitals nationwide are preparing for a third winter of COVID. Yeah. So they've got increased flu, increased RSV in children, staffing shortages that we've heard about, still tens of thousands of people being diagnosed with COVID daily. What concerns you, Dr. Hawkinson?
I mean, that's a huge concern, all of it, all the things we've been talking about the last couple of years. Luckily, we have been doing pretty well as far as capacity the last couple of years in regards to influenza. But we know Australia has had a really bad year. We do take a lot of cues from them. We know that the UK right now is seeing increased COVID, SARS-CoV-2 infections. Right now, influenza there is stable. We know in the United States, we still have very low circulation, but still, I think it's around 30,000 cases a day. Overall hospitalizations are down for COVID as well. We know influenza is low, but those rates are increasing, both the positivity rates and the amount of people going to the doctor to be evaluated for that. So I think it's very important, number one, to be vaccinated, be up to date with vaccination, and certainly, as we said, capacity. Hospitals around the nation have shortages of people working there, so we need to be able to staff those beds as well. And so it's very important for those employees to be healthy and be vaccinated so that they can continue to work and staff those beds as well. So I think we are all concerned about what will happen this year with COVID and influenza, not to mention all the other respiratory viruses as well. We'll just have to wait and see. I know that we are bracing for a higher amount or a higher number of hospitalizations than we have in the past couple of years. As far as influenza, hopefully with all the individual immunity based on vaccination and reinfection with SARS-CoV-2, we can keep those hospitalization rates down, and again, also with those outpatient therapies.
Okay, this is a study that was published in JAMA that you and I were visiting about yesterday, about 1 in 2 Americans didn't tell the truth when it came to COVID. About 40% admitted to breaking quarantine rules or misrepresenting the preventative measures that they were taking to reduce their spread. I don't know how concerning this is, or more is it, what would that tell us? Because this was in the height of the pandemic. Would we have been able to
I don't
draw
know.
anything from that information?
It's hard to understand how concerning it is. It's more of the pragmatic of, that's what we can expect and understand. I think we've just seen pieces of that with so much division in the United States for one reason or another. We understand that people also, for one reason or another, maybe we're doing that because they have to be at work, and understand that, maybe I do have it, but I do have children to support, or I have to do these things to continue to be at work. So I don't think it's surprising. I'm glad that we could have this study to look at those numbers, and I think it's one thing we need to continue to evaluate, but it's not too surprising, just understanding, I think the current climate that we're in.
Okay, I want to ask you about Uganda, currently battling one of the biggest outbreaks of Ebola. Why is this new outbreak particularly concerning right now? What could you tell us about that?
One of the reasons is also, so again, easy access to airports, flights out of the country, but also this current Ugandan Ebola outbreak is caused by the Sudan strain of Ebola as opposed to the Zaire. The Zaire strain, and again, these are strains, not variants like we see with SARS-CoV-2. The Zaire strain, we have vaccines against and some therapy. But with this Sudan strain, there is no current vaccine or therapy, so that is very concerning. There are 2 vaccines in the pipeline. We know that currently there are at least 40 confirmed cases, probably more than that overall, at least 10 deaths, and several in healthcare workers as well. So I think, number one, because of the strain itself, but also just the ability for this to get out of hand, that does cause concern, certainly here at the University of Kansas Health System. We are continuing to monitor that. If you remember, pre-pandemic, we had put in place processes and systems to evaluate anybody that may come to the health system with those types of symptoms. So we are continuing to be ready and continuing to prepare in case that happens. Hopefully it won't, but certainly we'll be ready.
All right, Dr. Hawkinson, thank you so much. Let's check and see if we have reporters on the line. Let's get to our community, and the first one is for Tracy. Mandy says, thank you so much for coming on and sharing your story, and just wants to know how you're doing today with your health and your breast cancer story.
I got something rare when it came to the chemos I was on. I have something that is called potassium wasting syndrome due to my platinum chemo that I had. And I have to do, thank God for CA11, it's the oncology nurses there. They kept me going. I was having to do 5 infusions a week. 5 hours of my day I spent at KU getting my treatment from them. And I just recently started this week to do home infusions. So I have to give myself my own potassium, but I am doing well in my cancer. At the moment it's stable. It's gone. I had a good result from the get-go.
Well, you become a familiar face around here, which we love seeing you, but not that often. We don't like to see you that often. But we always appreciate you coming on and sharing your story and talking to folks and being kind of the face of somebody who's willing to take and participate in trials. Sarah wants to know, why are minority women or women of color more susceptible to getting breast cancer? You had mentioned something earlier, Dr. Stecklein, but what do we know and what specifically is happening in the body?
So I think there are two components to this. One is that there are clearly some disparities in screening and diagnosis and how we approach breast cancer in vulnerable populations and women of color. So that's one piece. There are, as best we understand, some truly biological differences. We know, as I said, Black women are more likely to develop this aggressive subtype of breast cancer called triple-negative breast cancer. But I think a big piece that we need to address are structural barriers to access to care and screening in women of color and in other vulnerable populations, because we know that those patients today are much more likely to die of breast cancer. Some studies show that Black women are up to 40% more likely to die of breast cancer than a white woman, which is just abhorrent, and we need to do better than that. The encouraging thing is that there are data showing that if we address those structural barriers and we screen women early and we get them the same treatment and we encourage clinical trial participation, that we can actually dramatically narrow that gap and make outcomes basically the same between those two populations.
I'm so glad you brought that up.
Yeah.
One of the most important things to talk about is that access and equal care. Dr. White, Juan wants to know, are there international studies of vitamin C infusion therapy in breast cancer? You familiar?
To my knowledge, there is not an ongoing international study in the area where I work. I work on NCI, National Cancer Institute funded trials, and oftentimes we work together internationally through something called the Breast International Group, which is big. So to my knowledge, there isn't an ongoing vitamin infusion or specifically vitamin C. I think there have been vitamins studied in the past, particularly in the area of prevention. For all cancer, but to my knowledge, nothing ongoing right now on a large national, international scale.
What do we know about an artificial intelligence device known as 3D dimensional scanner? It's said to be capable of reducing unnecessary biopsies up to 20% of patients. Is that something either of you familiar with? Or would
Certainly,
be
it sounds like a great tool.
It sounds very exciting, but realistically, is that something that would even be close to being on the forefront?
I think that so far, how we make decisions about any cancer, let alone breast cancer, comes from confirmation with a biopsy. In the future, we think perhaps liquid biopsies might be a way around a tumor biopsy, but I suspect there'll be both types, complementary to one another's, actually the tumor and liquid. So I think imaging research has really advanced so that we're getting very good at identifying where things are, if they're there, how big they are. But to my knowledge, I don't think we're at the point yet where we're going to replace getting a tissue biopsy.
Dr. Hawkinson, Lindy wants to know, any news on bivalent booster shots for kids under 12?
We know that when the bivalent boosters have come out now for those over 12, the latest information was that within the next couple months. So hopefully within November, December, I know they are looking at all that data and all that information, but no other update other than they anticipated, the FDA, CDC, anticipated within a couple months after the rollout for those over 12.
I want to ask you before we get to final thoughts about how do people get involved with clinical trials? Is it patients doing research, which you know they must be doing in their spare time, and going to their physicians, or are physicians in the know with everything that's going on so they would know the best type of trial that they would be available to take? I just want advice from both of you about what route to take as a patient.
So I think both of those, to be quite honest. I think it's always a partnership when we take care of patients. We're together in sharing our decision making. So I know the trials that we have available, or where that might be nearly available, and so that I can say whether that would be a good choice for that patient. Always saying, you're volunteering. We acknowledge you're volunteering. But also sometimes patients will have learned about it through the internet, through shows like this, and if they bring it up, all the better. Even if it's not available here, we can help them try to find access to that. So I think it's a shared process.
It is, and it makes patients feel they have some type of control and active role in their healthcare, which is, I'm sure, what you both want them to do. Dr. Stecklein, what advice would you have for someone in a position like that, wanting to know more about trials? And what do they actually pick up the phone and call? Do they pick up the phone and call their doctor? What does it look like?
So I will echo what Dr. White said. I think we see some patients who are very well informed before they even see us, and they come in having an idea of a trial and want to know if that's appropriate for them. Our cancer navigation service, so this is a group of nurse navigators, are absolutely fantastic. And so when a patient calls into the cancer center with a new breast cancer diagnosis, they get in contact with a breast cancer specific nurse navigator who helps them organize their care, make sure they're seeing the right people at the right time. And they can also help them identify trial opportunities. We also have a huge group of fantastic clinical research coordinators that know the ins and outs of our trials front to back. Our informatics colleagues have actually helped us develop a couple of tools that our coordinators can use to screen every single patient in every single breast cancer clinic, whether that's surgery, medical oncology, radiation oncology, to try and identify trial opportunities for those patients so that when we see them, we can talk to them not only about the standard of care, but all of the potential trial opportunities
Those
that they
nurse
have.
navigators are like little angels.
Yes.
Would you not? Would you agree?
I absolutely agree.
They are so necessary and so important. Such an important part of the process for all of our patients. Tracy, I see you shaking your head. You've had some interaction with our nurse navigators. Is that what I understand? Tell us a little bit about that.
Yes, I lived out in South Overland Park, and so where I first went, I did a mammogram and ultrasound. I knew something was wrong. I just knew something's wrong because one side was just it was like a tiny balloon filling up every single day. And the other place I went to was like, oh, well, it's probably an infection. We'll start you on meds and then we'll do a repeat mammogram and ultrasound. Well, I called a friend who had gone through it years before, and she was like, call KU. I called KU. I got a nurse navigator. And she was like, she called me back. She's like, can you be here in 20 minutes at KU? I was like, sure, absolutely. And within 5 days, my tumor had gone from nothing to a 10-centimeter tumor. It grew that fast because it was lobular. It just went everywhere.
You didn't have time to wait for meds to kick in and then to do some mammogram down the road. And you kind of gave me chills, Tracy, because that's not the first time I've heard that. Can you be here in 20 minutes conversation? I know of women who have said they picked up the phone, called the cancer center and said, can you get in today? And then here you are. And so that makes me very, very happy that you knew your body and you knew to make another call and not sit around and wait. I want to get to our final thoughts. And Tracy, I'm going to go ahead and start with you. Again, just thank you so much. We can't really do the show. We can't tell these stories without you, the patient. So just final thoughts you'd like for us to know as we head out today.
I want you to leave here with the thought that clinical trials, the way they work is we can't move forward. We can't find helpful things that some of us have that are lingering without clinical trials. We have to tell them the problems. We have to be involved. We have to be our own patient advocate, which I have learned through Pivot, actually, on how to be a really good patient advocate for myself and ask the right questions. And also check yourself, know your body. Because most likely you're going to be the first one that feels like something is wrong. And, and keep pushing. I had the right doctor at the right time. Dr. Wagner's team, I didn't even meet Dr. Wagner until I was diagnosed. I had her team, unbelievable. And that nurse navigator, I couldn't function without someone telling me what to do because I just didn't know.
Well, and you've got so much going on too. It's hard to think through it all on your own, right?
It is. But, I mean, clinical trials have their pluses, and you have to kind of remember that they're not always going to work for one person. Our treatments are, I may have a certain type of breast cancer, but someone else may have the same type but be ER/PR positive and not HER2 positive like I was. And so the treatment could change a little bit. Everyone's treatment is catered to what they have, I feel.
Tracy, thank you so much. And again, we can't do it without clinical trials, but I think both of our experts here would agree we can't do the trials without the participants. So thank you so much for, again, being an advocate for everyone. And we will see you very soon.
Yes.
Stop by and see us, okay?
I will. Thank you.
You bet. Dr. Stecklein, final thoughts from you.
1 in 8 women will be diagnosed with breast cancer during her lifetime. It is a remarkably common disease. This is October, it's Breast Cancer Awareness Month, so I encourage every woman over the age of 40 to go and make sure she's getting her mammogram. Take 7 or 8 or 15 of your friends and help them get their mammograms as well.
I've been hearing those stories too. They're making a day out of it. They're shopping and they're lunching and they're having a girl time, but most importantly, there's a mammogram involved, and that is most important. Dr. White.
I love that. I would like to echo that and to say that, we want to support you through your breast cancer journey, and beginning with getting you in to be diagnosed, and then afterwards supporting you through any side effects or any lingering issues that come up, and just the changes in your life as you adapt to having a diagnosis. So and clinical trials are along the way of every part of that journey to help solve issues that are there for the next generation. And we really appreciate the volunteerism of our patients who go on trial and understand that they are helping solve the breast cancer problem.
Thank you both for being with us. Dr. Hawkinson, final thoughts today.
Yeah, I think it's just echoing what we've heard, and throughout this week and this month, it's just continued prevention and screening. Get out there, do that screening, talk with your medical teams. If you don't have a physician, please try to get access to one and get those screenings done so that down the line you can have that quality of life.
Doc Hawk, thanks so much. And thank you for being with us today. Don't forget you can catch our updates anytime by logging onto Facebook, YouTube, and Twitter. Go out, make it a great Tuesday. He's being called one man's hero.
And obviously, I understand where he's coming from, but just because I'm a very humble person.
How his stem cells made their way from London to Kansas City to save a cancer patient's life. Join Dr. Steve Stites for this emotional reunion and how you can help extend someone's life by 20 years. That's Wednesday on Open Mics.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.